TAVI was better above this STS score, above the age of 75 years. And we have today, we are expecting the acceptance of TAVI in patients above the age of 65 years in low-risk patients. This is expected to be obtained in 2021. Interestingly, the health authority in France are up to approve TAVI in patients above the age of 65 years at low risk at the end of this year. So this is a very important step for us in France. The TAVI valves will be reimbursed in France, even in patients younger with an age limit of 65. Today we have also many promising new valves. I don't put all of them here, but we don't know exactly whether these valves are offering better results than the previous valve, the Edwards and the Medtronic, but they are there and they are hugely investigated. I believe that the MyValve from Merrill, which is a balloon expandable valve, has a great future and with maybe a better price than the Edwards, so more available to be used in Asia. So TAVI in the future might become the default therapy for a vast majority of aortic stenosis patients because the procedural advantages of TAVI clearly outweigh its potential limitations. TAVI today offer valve implantation with local anesthesia, no sternotomy, no scar, early discharge home. This is extremely good for the patients. Less mortality, less stroke, less AF. The similar amount of PVL, the same amount of pacemaker in the SAPIEN 3 series, shorter length of stay and faster recovery. At the opposite, surgery may keep some good indications, especially in some bicuspid valve, especially when they are massively calcified in younger patients. Age below 65 years, I will come back on that. Less pacemaker than with the core valve, for example, easy reaccess to the coronary artery. Associated valve disease is also a good indication for surgery, as well as associated coronary artery bypass and acute endocarditis. Age and patient-informed consent will be key in the decision in the future. There is absolutely no doubt about it, even though there is no alarm so far on the durability of this TAVI valve beyond 5 years. Concerning this, we had 6 trials showing that there is no alarm so far, including the one that we did in our department with the longest follow-up, showing a total structural valve dysfunction of 3.2% up to 8 years. And reintervention rate in the old studies is between 0.7 and 1% beyond 5 years. So nothing really that we can fear. There was also some studies comparing the bioprosthetic valves and TAVI followed by echo, showing that finally even the surgical bioprosthesis showed some hemodynamic valve deterioration on the follow-up, which is quite comparable or even more important than after TAVI, with early hemodynamic valve deterioration below 2 years in 12% of the cases, and a midterm HVD of almost 21%. So more or less, you know, the evolution of these valves are quite comparable. So now that we are dealing with younger patients, the questions of the bicuspid valve versus tricuspid valve is there. And I don't think that we have to fear any discrepancy on the results as shown in many studies coming from Asia, and also in the STS ACC TVT registry comparing bicuspid and tricuspid valve, showing that more or less concerning the all-cause mortalities, the results are quite similar. So I would like to show you my personal views on the possible treatment options according to the age in the future. For us in Rouen and generally in Europe, above the age of 75 years of age, there is no questions about the superiority of the indications of TAVI versus surgery, knowing that in case of hypothetical early structural valve dysfunction, we can always do a valve-in-valve procedure, and the same in case of late structural valve dysfunction. So above the age of 75 today, we are pushing the patient to accept TAVI. Between 65 and 74 years of age, we have to inform the patients about the possibility of having a surgical bioprosthesis as an option, knowing that in case of dysfunction of the surgical bioprosthesis, we can always do a valve-in-valve procedure to solve the problem. Below 65, personally, I am pushing the patient to be operated on in Europe. It may be different in Asia, but below 65, I think that clearly we can say that surgical bioprosthesis is an option, as well as mechanical heart valves, which are always there. And if the bioprosthesis has a structural dysfunction in the future, it can be treated by redo surgery or valve-in-valve, depending on the patient age. In this category of patients younger than 65, I think that TAVI can be done in case of absolute refusal of patients to surgery, which is, I must say, often the case now. So age is key in the discussions and will remain key in the discussion in the future in younger low-risk patients below the age of 70. But in the absence of anatomical contraindications to TAVI, well-informed patients, whatever his age, refusing surgery, might have in the next future the deliberate choice of undergoing transfemoral TAVI, keeping in mind that surgery remains an option, emergency, urgent, or planned in case of unsatisfactory results or a valve failure during a follow-up. As you know, next to come, but already there, some other clinical indications on TAVI on the future. Bioprosthetic heart valve failure, we know a lot about it since thousands of patients have been included in the valve-in-valve TAVI registry. Concerning the bicuspid valve, I have shown you the slide of the US trial showing a similar outcome. And so I think that it's not a real problem, but we have to investigate a little more about it. We have also the indications of TAVI, which is investigated in severe asymptomatic AS patients. TAVI for moderate aortic stenosis and heart failure, with an international randomized trial ongoing. Maybe high-risk aortic regurgitation in some cases, and also are investigated TAVI in aortic stenosis with concomitant disease and in low-flow, low gradient. So expansion and future of TAVI, we are reaching today, and this is good for the future, a new paradigm. We started TAVI for patients who are not optimal candidates for valve replacement. And today, surgery will be indicated in patients who are not optimal candidates for TAVI. Thank you very much for your attention.
Thank you, Professor Cribier. Excellent presentation, brilliant expression of work, and your great endeavor and research work. I believe is a gift to the whole world regarding management of aortic valve disease. So I thank you all. That is the guest lecture. So you not ask any question to him. So therefore, you can discuss ourselves for 1 or 2 minutes. We will not ask any question to him. Dr. Hajra, any comment?
No, that was a wonderful lecture. I think we are progressing, but the unfortunate part that whether aortic stenosis exists in the eastern part of India, no, I do not know whether it is correct to state that. But the number of people we have seen our practice is not that great in number. Maybe Dr. Gupta, Dr. Suvanand can answer that. In western part, southern part, and northern part of India, there have been higher incidence and higher rate of TAVI. I do not know either we are missing the diagnosis or they are not coming to us.
Okay. Dr. Roy?
Yeah, actually, yeah, can I talk?
Yes, yes.
Yeah. Yeah, okay. So first of all, I congratulate Dr. Mantosh Panja to bring my mentor, Dr. Cribier, and I was very excited to see him. But he was, I think, his guest lecture. My comments would be that actually in India, yeah, you see what he has been doing was it's a balloon expandable valve, but Medtronic core valve has taken a little more lead because they were available earlier in northern part of India especially. And that's why more and more number of cases have been with the self-expanding core Medtronic valve, which is now available in a different way. Later on, the Indian counterpart, which is the MyValve, which is again a balloon expandable valve came up. The cost, basically the Edward was very specific in the cost, and also they were not able to do unless we have a registry in India. I'm talking historical 3 years back. Unless we have a special registry, GCGI would not permit Edward valve, or rather they were very keen that will not allow the Edward to be implanted unless we have a registry. I always had a hesitation, especially with Medtronic core valve, because the number of pacemaker implantation is little higher as in self-expanding as compared to the balloon expandable valve. So I consider that in India we are doing, and we've done few cases also in Apollo, but the cost detail is still there. Although they are doing something in 10 lakhs, but Edward, if you want to do it, it will cost no less than 20 lakhs. Unless the prices come down, we'll not be able to really advocate to all my patients who are really coming. Yesterday, I had a patient of 8-year-old. Yeah.
Okay, therefore, is thanks to Professor Cribier, and today what is finding the result of TAVI is that structural valve disease is improved, and therefore the durability of the valve is increased. Need for pacemaker also declining, and severity of the AR also declining, and all the complications, acute coronary, there is stroke and acute kidney injury, everything declining. Thank you very much once again, Professor Cribier.
Thank you, sir.
Okay,
Sir, SCI 2020, and this is 3 o'clock, and we have to start the formal sessions of the final day. And for this session, the chairpersons may I announce the name: Dr. H.K. Bali, Dr. Ranjan Sharma, and Dr. Rajiv Bhagwat. And the moderators of the session are Dr. Santosh Satish, Dr. J. Nayak, Dr. Imran Ahmad, Dr. Arindam Basu, Dr. Deepak Gupta, and Dr. Biswarup Mukherjee. So may I request Dr. Panja to invite the first presenter, Dr. Fazila Malik, and introduce her.
So, Professor Fazila Malik, she is the Chief Consultant Cardiologist of National Heart Foundation Hospital and Research. She is a regular invited faculties of different international conference, and her experience, particularly in intervention, particularly limb-mention disease, enough. So, Professor Malik, would you please start on your subject of talk on the bifurcation, that is how to manage by decay cross. Professor Malik, please.
We have 10 minutes for the presentation and 2 minutes for the discussion.
I can't get in because it says the host has disabled your participation. I mean, I can.
Can you see enable?
Yes, so my screen share is not. It's saying that the host has disabled your screen share.
Oh, that you can try again. Try again, ma'am.
Okay.
Better to rejoin her.